It's good to see everybody here still nicely bright and attentive. As you all see, this is our 18th TRICO, and it has evolved into a complex intervention course and imaging course. Before I start my lecture, I'm going to acknowledge and I want you all to congratulate Dr. Tejas Patel on getting not only successfully educating a very large number of people, but being honored by the Government of India with Padma Bhushan, which for all of you who don't know that, it's a true honor. It's a true honor to know him. So let's start this afternoon's lecture or didactic session with my story about how I incorporated IVUS into my practice. So for all those who don't know me, I'm Samir Pancholy. I'm from Pennsylvania. I was born and brought up in Ahmedabad, and I'm still in a private practice hybrid setting where I teach at a medical school, at a fellowship, and run a full old-style private practice. So how do you fit in imaging when you are doing 7 cases in 4 hours and you have to run and see office patients afterwards who are eagerly waiting? I don't have any relevant disclosures for this lecture. So the first question that everybody should ask is, why intracoronary imaging? And now it's very hard to refute the data that's out there, which is supporting the improvement in outcomes that we see if we guide our interventional strategy with the data we get from imaging. Whether it be IVUS or OCT, both modalities give you valuable data, and we saw the live demonstration of that here over and over again over the last day and a half. So why are we feeling overwhelmed and confused? If it is that good and the technology is so beautiful, we see it on the screen every day when we do it, why are we overwhelmed? Why don't we just embrace it? And why does it make us sweat even more? Well, there's no reason to be confused if you start analyzing what you're seeing. The biggest problem I see in imaging and in adoption is, and I hate to say this, that majority of the interventional cardiologists know how to mechanically do intracoronary imaging procedure, but do not know how to interpret what they record. And so the real investment for anybody who is going to start is to work on interpretation. What are you looking at? What does it mean, and how does it translate into a change in your angiographic guided strategy? And it comes down to 2 important aspects, especially when, I'm going to talk mostly about IVUS. I do OCT to some extent, but not as much as IVUS. And there are 2 large domains that you focus on. The first is lesion or plaque characterization, and the second is sizing. Imaging brings these 2 things to the table that angiographic guidance alone does not have as much precision for. Lesion characterization helps you with lesion preparation, and sizing obviously helps you with very precise stent metrics, what diameters, what size, etc. Angiographic sizing we have been all brought up with, and it's semi-quantitative, mostly eyeball sizing. We are actually better than QCA most of the time when we do eyeball sizing, although QCA is available and you can use that. So what happens when you go from angiographic sizing to imaging guided sizing? And this is a great study from Kubo et al. From about a decade ago, where they took a phantom and they compared the measurements gotten by OCT as well as IVUS. Obviously, phantom measurements were the hard truth, and this is what was seen in their study. An 8% overestimation, if you would, of the actual size of the phantom by IVUS, and OCT was actually right on the money. If you put on the same x-axis another graph from the same group in the same study and say, okay, how does the angiography compare to that? And as you can see, if the phantom and OCT are on the line, angiography actually slightly underestimates it, 5% less. OCT, surprisingly, is as good or closest to the truth as you can be, according to this particular study. Eyeball is all over the place. And that's one of the problems where I think we gain so much information about sizing with imaging that it's invaluable. So just from sizing alone, imaging is definitely a big help. Again, there are many, many systems out there, and this is a very busy slide from a group from 3 years ago, who measured the same phantom with different tools out there, different brands of catheters out there. Opticross, UltraView, Refinity, which is the high definition, and the top few are IVUS and the bottom few are OCT. And as you can see, majority of them are overestimating the size of the phantom, which is at the 0 line, which is the true size. And you can see there is definitely some overestimation, but it's not very large. For a 1.5 millimeter phantom, the worst overestimation was 0.12. So you're not overestimating by 50% or double the size. There is some overestimation, which is well accounted for, and even the definition of overestimation is up for discussion. The cheapest example for somebody who is a non-believer and you want to convert them is to put a 6-French guide, and when you do your IVUS pullback, and when you come in the guide, you ask them to measure the internal diameter of the guide catheter. And you ask them to look at the package of the 6-French guide, which says it's a 1.8 millimeter ID. And look at what your IVUS gives you, 1.8 millimeter ID. So those of you who believe that IVUS is overestimating and you need to adjust it, etc., majority of the time it's not. It's right on the money. And if you're not believing it, in the same case, you can confirm it with your guide catheter. You can measure your guide and it'll prove it to you. So let's get down to the basics. What is reference vessel and how do you measure? What do you measure? Diameter and area are the two metrics that we pay attention to, and the two sizes that we get are the size of the lumen and the external elastic lamina size, which is actually outside the media, between the media and the adventitia in the trilaminar structure. Again, you can see it in this classic picture from Gary Mintz's group, and you can see the black line outside is the EEL. The center small black circle is the catheter, and this is the lumen. And in between the intima and the EEL is the media. The intima is usually so small in the normal segment that, or so thin, that you don't distinctly see it. It's typically by IVUS. With OCT, you see it. Again, this is the reference lumen diameter. We measure it in two perpendicular planes. Let me just quickly run through this. Area is measured typically, as you saw multiple times today by Dr. Akasaka and the team at Apex. And we essentially calculate the plaque burden by doing area measurements both for the lumen and at the EEL. And it gives you the area stenosis, which is very important in deciding where to land your stents. So the reason to know all this is to figure out where are we going to land our stent. At the lesion site, we can make similar measurements. We see our lumen, we see our EEL, we see our area stenosis. And all this basics, or all these basics help you to follow these algorithms that have been published, especially lately, and have been systematized to some extent. So we start the procedure after getting a guide shot, etc. We put the IVUS catheter over the wire into the vessel. We obtain a segment which is within 20 millimeters of the lesion distally, and we obtain a part of the vessel which has a circular outline, if possible, which is the distal normal. How do you choose your landing zone? Well, it has to have less than 50% plaque burden by area stenosis, not by diametric stenosis, by area stenosis. That's your landing zone. And in the same pullback process, you're measuring lumen diameter as well, distal as well as proximal. Again, we talked about that, so I'm going to skip through that. And this is the reference lumen diameter calculation, which is the more preferred one. Or you can go and work with the EEL to EEL diameter, which is the most aggressive, because that's assuming that you can squeeze the media completely and expand your vessel, extruding the media out of the way. So depending on the compliance of the vessel that you guess by the plaque characteristics, etc., both of these are properly usable, and this is how you use them. For stent sizing, we usually, and this is based on the opinion study, which was a very well done study, we take the distal reference lumen diameter and we upsize our stent by 1/4 millimeter, and that is your stent size that you should pick. In the opinion study, it was the distal reference lumen. In the iLumen study, iLumen 3, where the operators realized by doing the previous 2 iLumen that just by going by the lumen was undersizing the stent, they recommended using the distal reference EEL-based diameter. If you use the distal lumen, upsize by 0.25. If you use the distal EEL, then downsize by 0.25. Very simple. It's not a whole lot of complexity. There is, but we're going to simplify everything. If the vessel is diffusely diseased or rapidly tapering because of large side branches coming out, especially in the LAD territory, then we tend to use distal reference lumen-based sizing. It's a little more conservative, and with the latest generation stents, you can expand them much larger than their original size that they are supposed to be at. So I can make a 3/0 stent go to 4/5, especially in some of the platforms. Not that I want to do that, but if I'm off by a margin, I could do that. If there's a large taper noted, especially in the LAD, we put 2 stents with minimal overlap so that we can choose two different diameters. Or we use stents which can be expanded to large diameters. In my lab, the Medtronic stent is the most capable of doing that. Remodeling is another phenomenon that you will run into when you start doing imaging, and it's very useful because it saves you from getting perforation type complications. Very important to understand it, study it. There are many intricate formulas that you can learn and calculate it. The OCT platform actually automatically gives you all these numbers by their artificial intelligence platform. With IVUS, you can calculate it manually and get the same thing. But it helps you in lowering your risk of overexpansion related complications. Positive remodeling especially needs to be identified and need to be bridged by your stent, and certainly avoid landing in those positively remodeled areas, because that has been shown to increase the future major adverse cardiac events. Plaque characteristics, again, another very, very important thing. And breaking this down into simplicity, it comes down to 3 things. Is there calcification of significance? Is it fibrotic, or is it neither of the two? The lipidic plaque is better seen with OCT-based imaging than ultrasound, although ultrasound can give you a very good hint at that. But your basic question you're asking for lesion modification is there enough calcification to worry about? Is there enough fibrotic plaque to worry about? Or can you just go with a balloon expansion strategy? How do you identify calcification? Well, there is echo density, and it is immediately followed by shadowing beyond that. So shadowing is very, very important. If you see shadowing, it's calcium. It's expressed in degrees, mostly by IVUS, because we cannot measure the thickness of the calcium by IVUS very well. Fibrotic tissue is echo density with no shadowing. And there are scores, etc., which are available out there, and you can read about them. This is the one from Zhang's paper from 2 years ago, using IVUS, where they can decide or help you decide when to use rotablation and when to go along with a straightforward strategy. Now this preceded IVL, so things have changed a little bit, but, with the advent of lithotripsy. But if you have more than 270-degree calcium and you can see calcium on your fluoroscopy, you should look and see if it's 360, is there a nodule, or if the vessel size is small or less than 3.5, then you should consider atherectomy. So let me just continue a little bit longer than what I have. But so procedure sequence-wise, take your guide shot, put your wire. The pre-IVUS, also known as run number 1, will give you all these sizing and lesion characteristic detail, which will tell you how to modify your lesion. Predilate rhoda if IVUS is not tracking. So if you try to put IVUS, doesn't go, it's an automatic reason to go ahead and do some form of atherectomy. Once you get your sizing parameters and plaque characteristics, you decide how you prepare the lesion. POBA, rhoda, IVL, or cutting balloon, depending on whether you have straightforward plaque, highly calcified plaque with a tight lesion or small vessel, highly calcified plaque with a good lumen, or a fibrotic plaque. Stent sizing based will be based on the algorithm that we talk about. Once you put the stent in, and this comes a little bit from the OCT literature, you divide the stent into two halves, so to say, the distal half and the proximal half. The distal half and the proximal half are treated a little bit as a different entity. The number one metric you're trying to measure is stent expansion. Why? Because it's the best predictor of future stent outcomes. What is proper stent expansion? And this is again where confusion sets in. There is a lot of definitions, a lot of different endpoints that different trials have used, and that's why we are confused. We don't know what to do with measuring stent expansion and the information that we get. These are some of the typical used endpoints. Your minimal stent area greater than distal reference lumen area is always a very good thing. If you achieve that, that's great. If your minimal stent area is greater than 80% of the distal lumen or reference lumen area, that's acceptable. If it's greater than 90%, that is perfect. Some studies have taken the average of distal and proximal reference lumen area from the doctor's trial, etc. And so again, the confusion in imaging comes from this variability of definitions. Again, we measure MSA. I'm not going to go into detail of that. Whenever we have an issue with MSA, ratio of MSA to your reference lumen, another metric that comes very handy is the absolute MSA. If your minimal stent area is more than 5.5 millimeters square, that is associated with great outcome. Now, is 5.5 good for everybody? No. These studies were done for vessels which were mostly 2.5 to 3 millimeters, and the stent length was less than 40 millimeters. So you got to be careful when you use 5.5. You can't use it for left main, and you can't use it for very small vessels. You got to use it for the generic vessels. The last thing I would say is, can we achieve these metrics in everybody? And this is a very educational and very revealing slide for me. This comes from a review from the European Heart Journal from a few years ago, but it shows that in most of the well-done trials, the operators who are very experienced were only able to achieve these MSA greater than 80% or MSA greater than 90%. These type of metrics were not achieved all the time. There was a fairly high prevalence of inability to achieve these ideal metrics. So if you don't get an MSA of greater than 90%, you're not alone. Lots of studies, and you saw that in our live cases. There were many good results that we left alone where the MSA was less than 80%. So I'll stop here because I don't want to take away too much of the extra time, and we'll talk about any questions offline. Thank you. Are you sure? Okay. Thank you. I will go on then. So let's talk about another big elephant in the room, which is malaposition. When I was taught about IVUS as a student and afterwards, I was told the only thing that mattered was malaposition. If your struts were not touching the wall of the artery, then the stent is going to close. It was probably true with the first generation PAMA shots and Cook stents, But with the latest generation stents that we use right now, there is good data to show that it's not the most important metric. What is malapposition? Struts not in contact with EEL? No. The definition of malapposition is presence of blood flow or lumen between the stent struts and the intimal outline. So if you have blood flow on both sides of the stent, your stent is not opposed. And you can see it in IVUS in this type of a picture that you see, especially if you have ChromaFlow or some sort of a flow measuring tool on your IVUS, you can see it very clearly. Again, malapposition is not the strongest predictor of outcome of a stent, but having said that, and this is coming from a study which examined a bunch of registries and found that people who had early stent thrombosis and people who had very late stent thrombosis in drug-eluting stent era, malapposition was fairly frequently seen in these stent thrombosis patients. So in the PESTO registry, you can see the red bars. Malapposition was actually seen more frequently than under expansion. In the burn registry, or actually the prestige registry, which is seen in the gray, it was the opposite. So there's a big scatter. One of the problems also is that stent thrombosis is a function of many things: P2Y12 sensitivity, stent strut thickness, etc. But at the end of the day, we know that malapposition is not as bad as under expansion, although it's not anything that we could take lightly. How about edge dissection? Three things we need to remember: a 60-degree or larger arc of dissection, a 2 millimeter, or some criteria would say 3 millimeter long area of dissection, and dissection at the distal edge, especially where the flow will extend the dissection, or as we call it, against the flow, is an important dissection and should be treated. If you're using OCT, you will see a lot of so-called unimportant dissections, and they don't need to be treated. IVUS is a little less sensitive, so if you see this on IVUS, it's most of the time probably needing to be treated. Stent edge hematoma, a very important finding, especially when you have a big step up and step down. Despite copious amounts of vasodilators, if that persists, you should definitely go image that and see if you have a stent edge hematoma. And if you find it, then treat it by another stent placement in that area. So our quick IVUS protocol, without extending the procedure in my cath lab for more than 10 minutes per case, is to locate the landing zone, less than 50% area stenosis, co-register with either software or manually angiographically by injecting contrast while the IVUS is doing its pullback, calculate the distal and proximal reference lumen diameter and area, image the intervening vessel segment, including the lesion, and decide on the plaque characteristic. Is it calcium? Is it fibrotic? Is it lipidic or soft plaque, or neither of the above? Identify areas of positive and negative remodeling, especially significant negative remodeling. And if automatic pullback is what you're using, then calculate the length. Otherwise, you can use markers on the IVUS catheter to get the length. These 4 measurements are routinely done in the first IVUS run. Based on the plaque characteristics, we choose our lesion modification platform, and then we pre-dilate or prepare the lesion based on that. Once the stent is deployed, we post-dilate the stent to the reference EEL diameter in that segment, proximal or distal. And then we do our second IVUS run. In this run, we are examining the distal edge, whether there's a hematoma or a significant dissection. We bookmark all the suspected minimal stent area and go back to them and remeasure them. One or more in the distal half and one or more in the proximal half each. We know our reference lumen or dimensions from the first run already anyway. The most important thing I have learned is visually inspect the longitudinal display on the side of the screen to detect the minimal stent area. That will give you a good idea of how your length of the stent looks. Calculate the MSA and then decide whether you have proper stent expansion or not. If not, then go ahead and figure out what to do with the numbers you have there. I'm going to run through this. So the last thing I would point out is this is a real case we did a few weeks ago. Patient had came with an inferior STEMI. We fixed the right. He came back for a stage intervention of the LAD, and you can see the proximal LAD looks like a good landing zone, right? Somewhere here we can land the proximal stent. Where's the lesion? Where you could see it in the mid segment. There is a bifurcation lesion. We were going to go with a provisional one stent strategy because the diagonal ostium was not that tight and was a short lesion. When we did our first IVUS run, we learned a lot about this vessel. The distal vessel was not that big, but there was a significant tapering after the diagonal. Lots of plaque burden, not a lot of calcium. And let me stop this and I'll show you what I mean by the longitudinal array. When you look at this part here, I can already see there is not a lot of calcium. There's no major shadowing. I also see the characteristics of the lumen there. So by looking at all this and doing those measurements, we basically identified our distal landing zone, reference lumen area, etc. But the most important thing we learned was our landing zone angiographically was somewhere there, right? When we look at that landing zone on IVUS, it looked very diseased. The area stenosis was 72% in that area. So our real landing zone was all the way at the ostium of the LAD. This whole segment was heavily diseased. And because of the greater than 72% area stenosis, we could not use the landing zone where the two red arrows are pointing. We had to bring it all the way down to the ostium of the LAD. Now again, after stenting, angiogram looks great. But as we all should know, if we expand our stents to greater than 14 atmospheres, properly sized stents, only 36% of the stents will reach or achieve the proper stent expansion criteria. Majority of them will be underexpanded. So post-dilatation is extremely necessary. And if you go less than 14 atmospheres or less than 12 atmospheres, you will hardly get any stent to be properly expanded. So that being said, this was our case. We found underexpansion. We used the proper EEL-based balloons, and we expanded our stent to the proper metric. A 4.0 balloon in this proximal LAD, which we never thought angiographically would be something that we would ever do. And after doing that, this is the final coronary angiogram. I don't have the final IVUS on here because of a corrupted file, believe it or not, and it worked here. We ended up stenting the diagonal ostium because of significant plaque shift as a provisional after procedure. So in summary, intracoronary imaging is an absolute must. It adds time and cost, but improves outcomes. It's difficult to show large improvement in outcomes because as we have adopted imaging, our stents have become better, and so we don't see as many subacute thromboses or restenosis anymore. But at the end of the day, there's definitely an improvement by using an imaging-guided strategy. Time added is to do the right thing, so we should never cut short with that, and always perform and interpret properly a pre-PCI IVUS. Measure your landing zones, your distal reference lumen areas and diameters. Stent size, I always use the distal reference EEL diameter and downsize by 0.25. And then my post strategy is based on both the proximal and the distal half and non-compliant balloon-based post-dilatation. Rarely we use lithotripsy after stent if it's still underexpanded. A second IVUS is always a good idea. Never say that my angiogram looks great and I'm not going to go look at it again, because frequently you'll be missing out on an opportunity to make it better. Thank you.